classify disease according to signs and symptoms, and so we look upon a disease as measles, or smallpox, or some other label that we might select, which we seem to think is appropriate to the signs and symptoms. And conceptually, we tend to think in terms of an entity, as though measles is an actual thing in itself. And there are a lot of metaphysical problems with this, and although when we're pinned down we might be able to explain the thing differently, it's very common for people to think that disease exists as a positive, distinct material entity. Further, in looking at medicine, I also had problems which were essentially epistemological. This concerned things like the nature of causality, and also with regard to specific treatment in relation to disease. It's common, of course, in medicine to speak of the action of drugs. And I think here, when we look at this, we have to see that there is a distinctly opposite view. I prefer to say that drugs have effects, they do not have actions, because the verb to act implies an actor. And when actions take place in the living organism, they must be ascribed to the living organism, and not to some inert, extraneous influence. Now, certainly we have to concede, of course, that drugs are capable of acting chemically, but we often refer to physiological or biological actions as being drug actions. And this presents, once again, certain serious epistemological problems. The hygienist tends to view health and disease, as I've said, on a continuum, as health being at the top of the scale, shall we say, we place health at the top of the continuum, and at the bottom we can place death. And of course, as this is a continuum, it's something that is fluctuating. It's a fluctuating quality of the function of the organism. And at a certain point, we might say, there is a point at which the symptoms or signs of disease will manifest themselves. And we might refer to this point as a point of toleration. And generally in health we're fluctuating in this area here. At this point, of course, we manifest symptoms. And these symptoms will develop, and of course if they are progressive, then we go down towards the more serious degenerative changes until we reach expiration. Now, as we're all well aware, health is not a static condition. It is a fluctuating quality that will vary from day to day or even hour to hour. And it's, shall we say, something of an autonomous coping with the conditions of the environment. The body has this ability to autonomously cope with environmental factors. Now, the hypothesis that the hygienists have developed has arisen over many, many years, and probably started with the work of Dr. Isaac Jennings, a Connecticut physician who was practicing around the 1820s. And Dr. Jennings is probably looked upon as one of the early pioneers of hygiene. And his argument was that disease arose as a result of a deficiency of force. The fact that the person became run down or exhausted, depleted, debilitated, or as we use the term today, enervated. Following Dr. Jennings was also a very famous physician by the name of Dr. Russell Troll. Troll was a prolific writer, a prodigious worker, and he argued that no, disease was not brought about by a deficiency of force. Disease was brought about as a result of a state of poisoning. The fact that our bodies were affected by poisons from various sources, foods, drinks, beverages, environmental influences, and so on. And he developed, along with Jennings, a rational and complicated theory of disease and its etiology. Now, later, a great debate took place between Jennings and Troll with regard to the cause and the nature of disease. And even today, I think that debate is available as a publication. It went on over many, many months and several years, in actual fact. And no agreement was reached between the two individuals. However, somewhat later, at the time of the latter part of the 19th century, there was one Dr. John H. Tilden. Tilden died around about 1940, and he saw that to some degree both these men, Jennings and Troll, were in part right. And Tilden was the first to see that it was possible to unify these two theories. And he put forward his enervation toxemia theory. And Tilden argued that disease arose as a result of enervation or a deficiency of force or debilitation, which disturbed nutritional processes within the body, checked elimination, interfered with metabolism to an extent that we had, developing within the tissues, an increase in the quantity of the intermediary products of metabolism. And that disease was an adaptation or a modification of the body's functions as a means of defense or adaptation to this metabolic change. And so this theory was somewhat unified. Now, the factors influencing the development of disease may be looked upon, we might come back to that later, as related initially to heredity, and of course our important environment, the other point I'd like to put in is use or function, something that is very rarely considered in this issue. We usually find that the only thing is heredity and environment. Now, heredity, of course, being what we're born with, and environment being what influences. And also we have this third point, which, as I say, is usually neglected, and that is the self-generated action of the individual, the use of the self, which has a very important influence on both of these other factors. Now, this concept of use I use in an extremely wide connotation. But this idea first came to me in my early studies of biomechanical factors, when I encountered one famous Australian, as a matter of fact, by the name of F. Matthias Alexander. Now, Alexander was merely concerned about use in the sense of mechanical use, not use in the sense of the total physical habit that I tend to employ the term. Now, Alexander was a Shakespearean actor. He performed in many areas of the world, but at the time he was settled in London. And Alexander, as a result of his reciting, lost his voice. Consulted specialists in a number of places, well-known specialists at the time, who would give him the appropriate gargles and other medication. He would recover his voice, return to his recitations, and lose it once again. After a period of time, being a relatively intelligent fellow, Alexander decided that he must be doing something when he recites that he doesn't do at other times, because in normal conversation he never lost his voice. When he was acting and reciting, he would lose his voice. So Alexander spent a great deal of time, 11 years in fact, more or less in front of a mirror, reciting, observing how he used himself, in what way he brought about this problem. And he published a number of books: Man's Supreme Inheritance, The Use of the Soul, Conscious Control of the Individual, The Universal Constant in Living. And he put forward an interesting theory. Put forward a theory that has been, of course, adopted certainly by the osteopathic profession. Although the osteopathic profession would probably not agree that they got the idea directly or indirectly from Alexander. That there is an important reciprocal relationship between structure and function in the body. Now, the osteopathic profession developed initially with the claim that structure governs function, which of course for a long time was an important biological principle. It has since been abandoned because it's quite obvious that function determines structure as well. So we have to see this intimate correlation, reciprocal correlation between structure and function. So I consider that very important in this triad is the term use. And this does not only mean mechanical use, it means the total use of the individual, how the individual uses the organism throughout life, the way in which they generally treat it. Another area of epistemological conflict in medicine as opposed to hygiene relates to causality. Now, from my point of view, the hygienic position is that disease, of course, is multi-causal. It is rarely, if ever, the result of one cause. And these multi-causal factors lie in many different areas. They may be purely biological, environmental, and they may be psychological, and they may be extraneous as well as intraneous. Now, in looking at the nature of disease, we find that in medicine, as opposed to hygiene, there's a great deal of confusion. And the term disease is often confused with causes, with consequences, with things that are only related to disease and are not disease per se. Now, if I can just once again draw your attention to a process of cause, process, effect. Now, you'll find that in literature, disease is often related to all three without any clear distinction. And if we look at acute disease, in acute disease, we find that it is considered to be contagious, infectious, communicable. So we speak of a contagious disease or an infectious disease. Now, once again, an assumption is being made because it is generally believed that these so-called infectious, contagious, or communicable diseases are related to microorganisms. Now, clearly microorganisms should fall into the category of cause. They are, shall we say, a cause, a factor in the cause. A microorganism is not a disease, and yet we're speaking about an infectious disease. There is no clear distinction made between the disease and the cause of the disease, or a cause of the disease. Now, once again, looking back on the germ theory of disease, this developed at a time when biological philosophy was in a state of flux. A great deal of controversy was raging. This is in the mid-19th century, and Darwin and Wallace had announced their theories of evolution, and the survival of the fittest was the order of nature. Huxley had depicted nature as red in tooth and claw. There was this tremendous competitiveness involved in nature, competitiveness for survival. And of course it was timely that Pasteur should announce his germ theory. This seemed to explain a lot. And it went along with the reigning biological philosophy that had developed during the 19th century. This idea of the survival of the fittest, the weakest to the wall, and so on. Here were these microbes that were going to devour and destroy us. But of course, at the same time, the controversy raged because a German microbiologist and physician, Dr. Robert Koch, argued that Pasteur had not discovered the cause of disease, and in actual fact was merely making extravagant claims. And Dr. Robert Koch formulated certain postulates which we merely read about in textbooks on microbiology these days. Maybe a brief paragraph about the work of Koch and his postulates. They're not taken seriously any longer, although I think they should be. Dr. Robert Koch argued that if the microbe was the cause of disease, it must be found in every case of the disease, which we well know that this is not so in all cases of so-called microbial diseases, that it must never be found apart from the disease. In other words, if we're capable of finding a microbe in the tissues of an individual and he doesn't manifest the disease, then obviously, why isn't it causing it? And unfortunately, this has very, very rarely been subjected to any serious scientific scrutiny. But it is a well-known microbiologic fact that often the microorganisms of highly virulent character associated with diseases are often found in the tissues of apparently healthy individuals. And I'm quite sure that if we were to take swabs of people here, throats and secretions and lungs and things like that, we would find microorganisms of a number of different diseases, and yet people would not be manifesting the symptoms of the overt disease. Consequently, that presents us with a difficult contradiction. Also, another of Koch's postulates argued that the microorganism must be capable of an independent existence. In other words, it must be capable of survival alone without the support of a host. And finally, he was of the opinion that it should be capable of being independently cultured in survival alone and re-injected into a healthy organism where it should cause the disease. And once again, we find that this does not stand up to scientific investigation, that sometimes the most highly virulent microbes do not produce disease. In fact, the famous German physician, Pettenkofer, who is often quoted, was the person who, in front of his medical students, consumed a test tube full of cholera microbes to demonstrate to the class that in the healthy individual they would not produce any problems. He was a brave man, of course. I think
Did it work?
I don't know. It worked. He demonstrated the point. I don't think I'd like to go that far, but anyway. So there are difficulties associated with this. And we know that microbes, aside from being believed to be the causes of disease, are absolutely indispensable to our life on this planet. And we can think of very, very basic functions of microbes in relation to our support. And they relate to nitrogen-fixing bacteria, for instance, which are essential for the development of proteins, which are so vital to in our food supply. But it has been possible for scientists over the last few years, the last 20 years or so, to develop various somewhat larger organisms in completely germ-free environments. And they've found that these organisms don't develop properly, adequately, and fully. The lungs don't develop properly and the gastrointestinal tracts don't develop properly. It does seem that this is that it is important to have these microbes as commensals or symbionts in our development. Their symbiotic importance, of course, has been realized for a long time. In fact, one biologist, Hermann Reinheimer, developed a whole theory of evolution following Darwin, based on symbiosis or cooperation between organisms rather than competitive struggle, which was, of course, the essential component of Darwin's theories. The establishment of these facts that organisms do not develop fully and adequately in germ-free and germ-free environments has led us to an understanding of the importance of bacteria in our development. In fact, one can take on the newborn baby. Newborn baby who is virtually free of bacteria, and within a matter of 24 to 36 hours the whole of the gastrointestinal tract is vigorously populated with bacilli, acidophilus bacilli. And these are fostered by the importance of colostrum, which is initially secreted by the female breast, which supports that type of bacteria, which is essential to the adequate utilization of the breast milk, which should subsequently follow. Now, along with this belief in the germ as the cause of acute disease, we have outlined and understood certain biological defense mechanisms that the body has. And the whole theory of immunology revolves around the body's response to environmental irritants, contaminants, and especially microbes. And in fact, the whole theory of immunization is based on what's known as the antigen-antibody theory. That an antigen, or some foreign material, protein generally, microbe, constitutes an antigen, and when in contact with the tissues will stimulate the body to respond in a certain way, which it does by the production of substances called antibodies, which are the body's defense against the antigens. And this sounds very plausible. And once again, like so many problems, when we come to investigate aspects of reality, we find that the theory sounds so beautiful, but when we look at the actual facts, they're not quite as accommodating. And it's been clearly shown, for instance, that the body's ability to defend itself against antigens is multiple and not purely related to this immunological response of the production of antibodies. And we find that there are children born with certain defects in the immune system. They are incapable, should I say, of producing antibodies. They suffer from a condition called agamma-globulinemia. And it's interesting, although these children are pretty sick, that they can go through some zymotic disease, such as measles, and recover quite spontaneously, as normal children do. And yet here's a good example of them doing so without the ability to produce any antibodies. So once again, that theory has a few holes in it, and the whole of the concept of immunization is really based upon that supposition. And looking at this as an aside, people will often say, that's interesting, now how do we account for the fact that we've eliminated things like diphtheria and poliomyelitis with immunization? Now, it's a historical verity that diseases are often cyclic. They do go through periods. They come and go. Looking at poliomyelitis, for instance, there was a massive epidemic of poliomyelitis after the First World War. In those days, it was referred to as infantile paralysis. In the mid to late 20s, it disappeared and didn't appear again until after the Second World War. And it was appearing in seriously epidemic proportions in the late 1940s. In the late 1940s, there were about 50 cases per 100,000 people. Around about 1950, the figure had dropped to 37 cases per 100,000 people. By 1955, it had dropped to 13 cases per 100,000 people. And it was in 1955, of course, that the vaccine was introduced. From the hygienic point of view, the disease was already on the decline. It dropped 50, 37, down to 13. So, once again, it's not possible to establish direct causal links between the procedure of immunization that was introduced and the elimination or the great reduction in the incidence of poliomyelitis. It may have been due to other factors. However, that does not alter the possible fact that we can maybe modify disease processes within the body by introducing foreign substances. And as one author has pointed out, we may have eliminated smallpox and typhus and things such as these, but we now have problems of cardiovascular disease, cancer, diabetes, and many other problems that may be considered much worse. And at this particular point, we might also look at another claim that the hygienist would seriously controvert. And that involves the fact that we are living longer today. Now, as a result of modern medicine, it's generally claimed people are living longer. Now, we should look at that also very critically. We have to appreciate that around about the year 1870 or 100 years ago, infant mortality was extremely high. Extremely high. In fact, in the mid-19th century, 1 in 4 babies died at birth. Now we're looking at a figure of, well, certainly less than 2%. It's rather interesting also in that context that America is not very high on the list of countries that have very good infant mortality for some reason. Neither is Australia, for that matter. But we also have this factor of the great reduction of infant mortality, and because of better standards of sanitation and public health measures, we've eliminated many of the diseases that were epidemic proportions 100 years ago: typhus, typhoid, cholera, plague, smallpox, and so on. And as a result of this, the statistics tend to suggest that people are living much longer. But as McKern points out in his book, The Role of Medicine, and René Dubos of the Rockefeller Institute stated in his works, that a man of 50 today does not have as good a chance of reaching 70 as a man of 50 100 years ago. And if we look at that still more critically, the man of 50 today doesn't have as good a chance of reaching 70 as the man of 50 100 years ago without suffering very seriously from one of the major degenerative diseases. So we do have an extremely crucial problem besetting us with regard to the evolution of chronic degenerative disease. Now, the hygienist point with regard to these factors as cause of disease, as I indicated earlier, we're looking at multiple factors. We would argue, for instance, in relation to acute disease, which is often related to microbes, that the microbes are certainly a factor, but they are not fundamental and not primary, that they are secondary or tertiary factors. Now, what support do we have for this? I think that probably the most significant support was provided by a study that was done in the United Kingdom and published in the Lancet way back in 1967, where the microbiologists were interested in the changes in the symbionts, or the bacteria that were present on organisms in hospitals where they were investigating. And they found that these commensal bacteria, when they observed them on different individual patients, they found that patients who suffered in the hospital, say acute myocardial infarct, or perforated duodenal or gastric ulcer, that the bacterial flora on the body changed, and they changed within about 20 minutes of the acute episode. In other words, a person would have acute myocardial infarct, and within 20 minutes, the bacteria found on the body, normal commensals, were starting to change. A person would have a gastric ulcer, it would perforate, and within the first 15 to 30 minutes, there would be a change in the bacterial population in the body. In other words, the patient's health is changing first. The bacteria change secondarily, which tends to support the hygienic viewpoint that the health of the individual determines and regulates and controls the bacterial activity. The bacterial activity is not primary nevertheless, in disease being such a complicated fact, it is certainly a very important factor that we consider microorganisms as being contributory. They can certainly elaborate powerful toxins, as evidenced in such things as Clostridium tetani, with the tetanoplasmin and tetanolysin, which has a powerful effect on the hemopoietic system and also on the nervous system. Now, it's been pointed out, for instance, in any epidemic disease, and taking an example of that, poliomyelitis, everybody in the community has the virus. Certainly it's circulating in the community. It would be very difficult for a person to live in that community without contacting the virus, and yet not everybody is sick. So consequently, we would certainly argue strenuously that health determines the reaction and controls the action. We know that, and there's good support for this, that in the development of disease, and we're thinking in terms of epidemic disease, contagious, infectious, so-called disease, there's a term called host resistance. Now, once again, we find the difficult epistemological problems that we have in conceptualizing these things when we use such terms as resistance. We're left asking the question, resistance to what? And the person will say resistance to disease. Now, if we follow this through, logically, resistance to disease. The organism resists disease. Now this gets us back again to this entitative concept, as though disease is something out there that has some independent existence aside from the living organism. Disease is something out there, it's an entity that we resist. Now, that's very, very difficult to support. Anything that we might be resisting, and certainly when we talk in terms of microbial host relationships and the host resistance, what we are resisting is the cause, i.e. a cause, microorganism, not disease. Hence the confusion. Now, I believe that we don't resist disease. I believe we produce disease. Disease is an action on the part of the living organism. You look at the symptoms of fever, inflammation, coughing, spitting, diarrhea, vomiting. These are actions on the part of the body. These are symptoms and signs of disease. The body is acting. And what I would say, and the hygienist would argue, is the body does not resist disease. The body produces disease, and the disease is the process, or part of the process, of resistance. It's part of the process of resistance to multi-causal factors. And, of course, among these multi-causal factors, of course, are microbes, or certainly types of microbes that will elaborate toxins which will irritate the tissues. Now, in looking at the principles of hygiene, and coming back to this again in a minute, the hygienist has laid down certain basic principles which he thinks are important in understanding the nature of health and disease, understanding the recovery of health, and in indicating the direction in which we should go in order to develop a proper and appropriate health science. First, he would argue that there should always be a normal relationship between the living organism and the factors of the environment which are provided to support that organism. So we see that there is a normal relationship between food and the living organism. As there's a normal relationship between food and the living organism, fine. Food is something which is constructive, which will provide material of use, which is important to support life. But food is nothing more than a material of use. It is something that the body can actually use to construct tissue, to utilize in the performance of its functions, to elaborate the materials necessary for health, reproduction, healing, and so on. Food doesn't do anything, it is merely a passive environmental factor, something that the body can take and use. Now we have ideas about food as though it has some special magical quality. You know, the Diet Does It Brigade, the people who believe that, food is your best medicine and all that type of thing. Food is only material of use, something that the body takes, and it's what the body does with it. And of course we have all sorts of problems with, once again, epistemological. You know that food builds strength, food builds resistance. So one always has to ask the questions, well, how is it that well-fed people get weak? How is it that well-fed people get sick? How do the strong become weak if they're taking sufficient food? And this, of course, translates into another area where, of course, the person who's sick has to be given plenty of good, nourishing food to build up their strength. And as they're given this good, nourishing food, they get weaker and weaker, which will lead us eventually into another area of thought, and that concerns the subject of fasting. Now, to the hygienist, this fundamental principle of a normal relationship between the living organism and the factors of the environment which support it is crucial, because that guides us in our care of the well and the care of the sick. Now we know there's a normal relationship between food and the living organism. We know there is not a normal relationship, shall we say, between alcohol and the living organism. The man who went to the doctor and the doctor was examining him, he said, hold out your hands. He held out his hands and it was shaking. He said, goodness me, do you drink much? He said, no, I spilled most of it. So we can look at things like an area such as cancer. Unfortunately, I have a somewhat extreme view in regard to this, and I think that it's rather regrettable that people who suffer from cancer also have to suffer the indignity of a tremendous amount of abuse before they die. And we think of the, I would call, mistreatment of these sufferers, the fact that they're either treated with surgery, which is probably the least objectionable, chemotherapy, the most violent form of drugging, and these chemicals, of course, that have no normal relationship to the living organism, going back to our first principle. And finally, radiation, a well-known cause of malignancy. Once again, having no normal relationship to the living organism does not enhance function in either health or disease. So once again, it's quite common in conventional medical practice to employ causes in the treatment of disease. And this, of course, gets us back to this very fundamental principle. Now, medicine, generally speaking, is an empirical system. That means it is based on experience. And people talk of modern scientific medicine, once again we can go into a whole area of the discussion of the philosophy of science. The loose sciences, like the biological sciences, are areas which are very difficult to deal with, and in dealing with such a complex situation as the sick individual, very difficult to be strictly scientific about it. So medicine is essentially an empirical system. And I would make a distinction between an empirical system based on experience and an experimental system which tends to be more leaning towards the scientific. On the other hand, the hygienic system tends to be more of a logical system. This doesn't mean, of course, that because it tends to be emphasizing a logical aspect, that it has any contradiction with empiricism. Certainly, if logic is to be any use at all, it must be supported by empirical factors. But I would say that hygiene is more of a logical system, understanding certain fundamental principles. And looking at this first principle of the normal relationship between the organism and the environmental factors which relate to it, we can say that we might start off with certain basic axioms. I mean, everybody has to start somewhere. The scientist has to make the assumption that reality has some independent existence. He has to make the assumption that his own brain is capable of understanding this thing or this factor that he calls reality. So the hygienist also makes certain assumptions, starting with certain axioms or axiomatic concepts. Now these axiomatic concepts start off with that the living organism is self-constructing, self-defending, and self-repairing. That seems fairly basic. The living organism constructs itself from the fertilized ovum. The power that builds the organism is resident within that fertilized ovum, and providing it is supplied with the necessary environmental influences, food, air, water, etc., it will grow and develop. The power of construction is resident within the cells. That the body is self-defending is once again self-evident. That it is self-repairing is also self-evident. So these are really the basic axioms that hygiene adopts as a starting point. The living organism is self-constructing, self-defending, and self-repairing. That means that the mechanisms of healing are intrinsic. That healing is self-healing. Healing is a biological process. It is something that the organism does for itself. It is not something that somebody does to you or that somebody does for you. So from our point of view, there is no such person as a healer. Healing is something that is spontaneous. It occurs within the living organism. It's a process which is an inbuilt mechanism within the organism. So healing is self-healing. What we have to do, what we have to try to understand, are what of the factors, what are the conditions that we have to provide that are going to, shall we say, encourage the organism to heal? What are the factors which are going to enable it to accomplish its remedial processes, to restore itself to normal when it is damaged or sick? We also have to look at what are the factors, and this is crucial too, that are going to prevent spontaneous healing from taking place. I remember many years ago, way back in 1967, and I'll relate this case a little bit later, the person who was extremely sick, they had what I believed at the time, and many other physicians believed as well, terminal cancer. But we decided, to consultation with the patient and the family, that we'd try certain procedures. And nobody was more surprised than I when the patient recovered. The hospital, one of the major hospitals in Sydney, Australia, who conducted the original investigations, ran the necessary tests again, and the person was well. They could find no significant evidence of the pathology that previously existed. Now, okay, they said spontaneous remission.
Pretty words.
Yes. Now, of course, I don't mind that. Anybody who recovers health, it's a spontaneous remission. Because the ability of the organism to restore normality is a spontaneous phenomenon. It's something that's resident within the tissues. The only thing that we have to learn, and I don't claim to have learned it, I have some of the answers, but certainly by no means all of them. I'd certainly like to know a lot more, is how we can encourage a spontaneous remission. How we can provide the conditions and remove the impediments so that a spontaneous remission can occur. I think that's very important. Now, as I say, in medical literature, we find the word cause is used as a synonym for disease. So we find, as I say, infectious disease, contagious disease, communicable disease, when they're really referring to the cause. The fact that the process of disease is related to disease is fine. Well, the person produces symptoms, so they have something like pneumonia, they have chest pain, fever, cough, maybe expectoration, consolidation. These are all related to processes within the body. Inflammatory processes, so we have the vascular response, numerous immunologic changes, fluid shifts, electrolyte disturbances, and so on. These things are obviously processes of the organism. Modifications of normal bodily processes, normal physiology, which has now become what we might term modified, some people think perverted, and it becomes pathological. And the distinction between physiology and pathology, which we look upon in the term of pathophysiology, is merely in the intensification or the modification of the function. So we might say we'll look at a symptom such as diarrhea. Well, it's inherent in the function of the organism. In the case of diarrhea, then the function of the particular part is just a little bit more intense than the normal function. There's an acceleration of the function of the bowel. We look at other symptoms like alterations in blood pressure, alterations in heart rate. So in tachycardia we have an acceleration of function. In hypertension we have an elevation of blood pressure regulated by the nervous system. But these are all processes. They are processes of the living organism, and therefore it is correct to refer to disease as a process. Now, when this process concludes, there may be a certain amount of damage done to the organism. A certain amount of degeneration has occurred, which is the effect, which is quite distinct from the disease as the process. And the effect has been brought about by the cause, not by the disease, not by the process, but by the cause. Now, let me give an example of this that makes this perfectly clear. I take my hand and I place it on the table, and And I also take a mallet or a hammer, and I strike the hand, foolishly. And the hand is torn, ligaments are separated, bones are fractured, blood vessels are ruptured. Well, let's have a look at that. The cause, the hammer, quite distinct from what is taking place in the hand, where we're going to get changes taking place as the blood congeals. Inflammation occurs as a process of the healing, and eventually the bones will knit, the ligaments will regenerate, blood will clot, and healing will take place. That is the process. So we have the hammer and the process of healing. But what I'm left with afterwards, the hand is deformed. An effect of the cause, not of the process of the healing, not of the inflammation, not of the knitting of the bones, but of the hammer. Cause and effect. And in the middle is the process, which is the body's means of dealing with the cause. A means of defense, adaptation. Disease is multiple in its function or process. Disease we might look upon as defensive because it involves the body's defense mechanisms, the way in which the body handles environmental influences. It's remedial in the sense that it's also part of the process of healing, where regeneration occurs. It is adaptive in the sense that if it cannot escape causes, adaptations will take place. We have a distinction also between acute disease and chronic disease. A chronic disease being more adaptive than acute disease, but adaptations do occur. Now, to look at this process of adaptation once again, we can say that in adaptation we have a certain amount of toleration to an influence that is possibly not beneficial. Now, an example, for instance, just from everyday living. A person who does not drink, for instance, the social drink of coffee, might take a cup of coffee, and there might be quite a dramatic effect. There will be increase in the heart rate, increase in the respiratory rate, increase in insensible perspiration. The vascular response will be significant in peripheral vascular changes, and the effect will be quite dramatic. The person may themselves observe quite noticeable psychological and emotional changes. They seem a little bit agitated. Now, on the other hand, the person who regularly consumes coffee, we won't notice any of these effects because adaptations have taken place. Because of a cause that the body couldn't escape, a cause that has been applied over a long period of time, and a toleration has developed. Now, we see that also in relation to tobacco smoking. I mean, most of us at some stage in our lives have tried tobacco smoking. I know when I was a young fellow I did, and almost regurgitated my lungs. But of course it was obvious to me at the time with smoking that my body was indicating unmistakably it didn't really want it. It was coughing, it was uncomfortable, and so on. But I realized that if I'd have continued, I might have even got to enjoy it. A toleration would have occurred. Now, This, to the hygienist, is the point where we make a distinction between acute disease and chronic disease. Chronic disease involves a certain amount of toleration or adaptation because of many causes that have been applied over a long period of time. The body is unable to expend the energy involved in acute disease, because we must realize that in acute disease, this process is an expensive process. It's extremely energy consuming. And as we know that in acute disease, often one of the symptoms of acute disease is prostration, because there's so much energy involved. With high fever, acceleration of circulation, respiration, and so on, a great deal of energy is being consumed. And we also know that in acute disease, that taking large quantities of food, and particularly large quantities of protein, cannot maintain nitrogen balance within the body because of the body's inability to adequately utilize the food under the circumstances. Acute disease being such an expensive process, and the fact that the energies of life are not inexhaustible, sooner or later the organism has to conserve that energy expenditure. And we see a distinction between acute disease and chronic disease. The disease process becomes less energy expensive as adaptations take place and less energy needs to be expended. But I do want to emphasize the importance of having a clear conceptual understanding of the distinction between cause, the process of disease, and the effect of the cause. So one might amusingly argue, of course, that nobody ever dies of disease. They're killed by the causes of disease, because it is the cause that's going to bring about the process, and it is the cause that is going to produce the ultimate effect, whether that is damage to the organism or even, on our other scale, death. Actually, I think it might be appropriate if we can take a bit of a break there, and maybe we can have a few questions for a little while. What do you think?
You want to take questions before we take a break?
Well, yes, I think so. I think I've said enough to confuse you so far, so perhaps if we do take a few questions, perhaps clarify some of the points that are latent in what I've said.
How does an epidemic occur? I thoroughly agree that germs don't cause it, but I can never explain how epidemics occur.
I don't know that I can explain it either, but I'll make an attempt. Epidemics will often follow some mass prostrating influence. Some mass influence like war, food shortages. I mean, you notice in your Bible, the four horsemen of the apocalypse, and you've got what you find always related to epidemics, famine and pestilence. There's often a relationship there. Environmental factors such as weather, meteorological factors, the fact that you'll get epidemics after an intense summer or an extreme winter, things of this type. But I think that these are poorly understood because, once again, they have never really been subjected to any thorough investigative analysis. The reason for that, I think, is not so much that people are not interested in it, but the fact that it's incredibly difficult. A lot of people would be interested in it, but to do it would be very, very difficult. I think we can see a lot of evidence for the support of a mass prostrating influence. And there's also, of course, a lot of biologists and a lot of people in medicine have not really been interested in the subject because they're already satisfied that microbes, viruses, bacteria, and so on are major causes. And whilst they will give lip service to the importance of nutritional factors, say in host resistance, they tend to look upon the virulence of the microbe as being the chief factor. But I'd say in epidemics you notice certain things, that the death rate is usually highest in the earlier part of the epidemic, and that's when, as far as we're concerned, the most debilitated, the most enervated are likely to develop the disease. The death rate is always highest among the older people in many epidemics. And there are also older people are affected more in the earlier part of the epidemic. But even in an epidemic, I mean, one always has to argue that, although it's purely theoretical, that in an epidemic there must always be a first case. How do they catch it if we're going to accept the principle of this communication? But then again, I mean, one has to also accept the fact that communicable or so-called infectious or contagious factors are at work. In other words, I'm only saying that I don't believe this is primary. I'm not suggesting for one moment that the bacteria don't have any influence. They're very important factors in these so-called diseases. All I'm saying is that they're not primary factors.
The question that I have about it is, if you have a situation such as war, people are under stress, the body's immune system is broken down, or whatever. Why does the epidemic become, say, the Black Plague or something like that? I mean, why don't some people get Black Plague and some people get measles and some people get...
Well, in actual fact, to some extent, that does happen. And in fact, we've noticed a number of times that the boards of health often have difficulty in determining the label that they're going to put to it. And often they will use a term which is, of course, medically very loose, like influenza. And you'll find gastric flu, intestinal flu, bronchial flu. And there are many different descriptions because there is a wide range of symptomatology produced among the sufferers. So it's not always clear what the so-called disease is insofar as description of signs and symptoms. It's not always that clear, but there is a wide variation among the sufferers. But I would say that we also have to consider that the microbes too are related even more critically than we are to environment. So in a certain type of environment, the type of microbe which is associated with the disease will be of a specific type. And we might consider that the microbe is a determinant of the type of disease because of its own activity in the community, the production of toxins which will elicit a particular response on the part of the organism. And once the microbe has, shall we say, to use the medical terminology, invaded the tissues and elaborated toxins, then the organism's response as it's mobilizing its defenses against, once again, a cause, then the type of response is going to be similar. So as I say, I think the microbial development is going to also be related very critically to environment. So you're not going to get, say, the activity of the poliomyelitis virus in the wintertime. You're not going to get the activity of the pneumonia, pneumococcus in the summertime. It's going to be related to environment as well. But I think it's a very complicated thing, and so many factors are involved. It would be great if somebody could spend a few millions of the public money to investigate the problem.
Thank you.
Yeah, I have trouble with reproduced disease. I can't. Environment isn't such a big factor. Is what you're saying, that our environment
No,
are
I'm saying
being.
environment is a big factor. I'm saying environment is a major factor. And looking upon environment in the widest sense to include, say, nutrition, which is
All right.
probably our biggest contact
Yes.
with the environment.
Yes, nutrition. But on the other hand, you're saying everyone doesn't get the same disease if they're exposed to the same thing, like the guy that drank that. You know.
No.
So
everybody doesn't get the same.
what is in our changing bacteria in our body? Is that what causes us to get the disease and this other guy doesn't? Is our bacteria in our body changing due to the food we eat?
Now let's just look at this again.
You're going to get a disease that I'm not going to get. It's
Right.
because the bacteria in my body has changed due to diet. Is that
if
the way you would simplify
if
it?
it's a bacterially related problem, yes, I would say that you are providing a suitable environment. Because of your level of health, you are providing a suitable environment for the bacteria, whereas I am not.
Okay.
And that may be determined by a wide variety of environmental factors. Of course, a major consideration there is nutritional status. It's got to be considered as important. But I'm
Okay.
saying the
separating
environmental
that.
factors
All right.
are predominant. And we have to consider bacteria as part of the environment as well, in the total sense. But the bacteria may be considered as determinants. The fact that as a result of the toxins they elaborate and the activity that they engage in, that they will have an influence on the type of response that the body makes in producing the disease. Now, to say that the body produces disease, let's have a look at an example of that. If I take a glass of a glass of water, and inadvertently it's been contaminated in some way. So I drink the water, and my body is going to respond to that because of this is contaminated water. So I might get fever, vomiting, diarrhea. I mean, anybody who's been to Mexico has probably experienced this.
But you might
Now,
not, too.
I might not
You
too.
might not. That's the point.
Right, no, yeah, but that's only a point in regard to a very fundamental thing that I have stated. The fact that it is the body that produces the disease. Now, maybe the body can handle that toxin without intensifying any function. It can detoxify it in the normal way. I mean, let's face it.
Why?
Why? Well, the body is a poison factory to begin with. Why? Many...
What do you mean by
I'm studying this now. I'm studying the turning points
Right.
for a course I'm taking.
Uh-huh.
You're including nutrition as the environment, though.
As part of it.
Right.
Mhm.
Whereas I think he's separating it
Uh-huh.
as a different, the
Well, I think
environment's
that
one thing.
nutrition or food is
nutrition, yeah.
is our major contact with the environment.
Right, yeah.
But the important thing is that if I consume this contaminated water, my body's response could be anything from virtually completely unconscious, I'm not aware of any change, but it will still deal with the toxin, to the most violent fever, nausea, vomiting, diarrhea, abdominal cramps. Now, why would one person manifest that and another person not to the same cause? Because we have the same cause, but the object upon which the cause is having an effect is different from each one of us.
Yeah, not
I mean,
everybody
each
that
one of
goes
us,
to
as we
Mexico.
know, are unique, just like everybody else.
Could it be because each individual body has its own toxic level? So that if you are already saturated with toxins, you're really going to react harshly. Whereas opposed someone who's got rather a clean system.
That's part of the individuality.
Right.
Yes. Okay, you have mentioned part of it. The body has its own, shall we say, established toxic level, if you like to use that expression, fine. But that's part of the individual makeup and part of the individual status at that particular time. That's why at one particular time you might get sick and another time you might not get sick. Which gets us back to the other point I was mentioning here with regard to this level of toleration. If I can go back again to just talk about this, we have a health fluctuating here, there's a fluctuating quality. We become debilitated and we go below our level of toleration. The body will respond. It will respond by producing symptoms. Those symptoms are related to either a diminution or an acceleration of certain bodily functions. And that may be partly remedial, defensive, and eliminative. I will take a simple example. I mean, to many people, on Monday morning the person seems to be quite well. On Tuesday morning they have a heavy cold. They're somewhat feverish. The upper respiratory tract is irritated. There's a lot of mucus which is streaming from the nostrils. Now, to most people they were healthy on Monday. On Tuesday they were sick. To me, on Monday they were sick, on Tuesday they're getting well. Now, okay, because we now got beyond the level of toleration, and the body is responding and is acting to get them back up there again. And it's a spontaneous remission. The body will spontaneously produce the process and they will recover. Yes?
That's not a line across there, that's a band or a series of bands across there. Toleration.
Okay, I'll agree with that. In fact, that was going to be another point that I was going to come to. The fact that, as we look at toleration, now I mentioned previously about acute and chronic disease, as adaptations take place, we get toleration occurring at different levels until finally we reach the ultimate toleration. That's the point you're making, right?
Yeah, and then you have the marginal person down below.
Yeah, we have the person fluctuating in here who's
Marginal.
marginal, that's right. Well, that's a very good way of looking at it. So what happens, in optimum health we have an area of fluctuation here. Now a person will say, right, well, you know, real health is rarely placid. It always worries me when a patient confronts me and I'm taking a case history. And they say, gee, I'm real healthy. Until this arrived, I hadn't had a cold in 10 years. Been so well. Now, in modern life, that doesn't augur too well for them. Because I find that it's so difficult in modern life to live such a thoroughly composed, hygienic life that you can maintain optimum health under all conditions and circumstances without ever getting just a little bit below here. Very difficult. I mean, usually, I've visited the United States many times, and usually in the middle of the year, around about July, and I find that I get on an aeroplane in the middle of winter in Australia. I arrive in Los Angeles half a day later, 12 hours later, in the middle of summer. Apart from the fact that it's in one place the middle of the day and the other place the middle of the night, you know, this is an enormous stress on the organism. As my wife and I recognize that almost invariably we'll be producing symptoms within a week or so. The stress is considerable, and the adaptations that it demands on the part of the organism are great. So we'll usually, as a result of this, push ourselves below this level of toleration. And so we might get a sore throat or a bit of a cold or something like that, or a bit of a stomach upset, last for a few days and recover quite spontaneously, no problems. You're back up in here again. There's a remedial, defensive, adaptive process associated with causes which of course are pretty obvious and straightforward. Right. Yes.
On the last chart with the cause, process, and effect, given that the organism is self-destructing, self-defending, and self-healing, how much autonomy do you give to that organism? Because if the effect of some of the causes could be severe without some kind of modulation or intervention on the part of the...
Well, of course, there is a rational limit placed on this. I mean, I consider that as far as the process of healing, the body's mechanisms are concerned, then the autonomy is absolute. But when you're talking here about, say, medical intervention. You thinking of that type of thing?
It's open. I'm not thinking necessarily
right.
of that.
Well, I can see that, and this is where the art comes in, of course, is making the appropriate decision of interference and intervention, which is obviously necessary in some situations. It's sometimes necessary to intervene to remove causes which can be types which may be largely mechanical, or, for instance, the body's ability to adequately handle the cause with the process may be limited. I mean, I think of situations where the process is so overwhelming that intervention may be necessary. One can think of this in relation to, I mean, I would say that, for instance, something like acute appendicitis. In 95% of cases, I'm sure that can be quite easily handled without resort to surgery. There is a small percentage of cases where It is beyond the constraints of the body to be able to deal with it. And unless surgical intervention is adopted, the person's going to die. The fact that disease is adaptive, remedial, and defensive, and so on, and the fact that the body's remedial processes are autonomous doesn't mean to say it's always going to be successful. It may not be.
Dr. Lynn, when you say it could be handled without surgery, what would you do?
What would I do? Well, do nothing intelligently, I suppose.
What would you have the patient?
Well, actually, this was the turning point in my own career when I was at medical school. I developed acute appendicitis along with a lot of other problems that I had. But that was the culminating thing. And, well, I do what I did at that time and what I've done for many, many patients since that time is absolute bed rest, complete abstinence from all food, very little water, and for the patient to keep as still as possible. And spontaneous recovery will occur in 95% of patients. After all, we have an inflammation, and an inflammation is circumscribed pathological process that one gets in many different situations, like tonsillitis, pharyngitis, hepatitis, gastritis. It's self-limiting. In 95% of cases, inflammation is self-limiting. It is with appendicitis, and I've had literally hundreds of cases of appendicitis that recover within a few days to a week with no problems whatsoever. But very, very occasionally, one will have to resort to surgery. Yes.
All right, again, supposing you're faced by some young people and they say, junk food is bad for me, why don't I get sick?
Well, the fact is that they do. It's the question of
They
the
do get sick,
identification.
but a lot of them don't, too.
Uh-huh. Right, okay, well that brings us to our point back here, doesn't it, which we mentioned about this factor. That's extremely important, and of course associated with environment, food being an important part of environment, but there are also other important parts. I mean, the young person may be vigorously active in sport. They may be very, very psychologically well adjusted. They may be emotionally poised and things like this. There are so many compensating factors that may enable the body, because of its background and heredity, to stave off the day when any overt disease does manifest. I mean, one can point to numerous examples in history of people who have obviously abused their bodies and have lived to be fairly old age with relative impunity. But we have to look at this question statistically. What is the usual? Now, you're looking at the young people. I don't see the glowing health that tends to be implicit in your question. Seeing a lot of young people, I see them with lots of health problems. And I think that one of the major problems in my own practice that I encounter are problems, many venereal problems, for instance, that readily comes to mind, that many of these young people do have. I think of many skin problems, gastrointestinal problems, upper respiratory tract infections, chronic catarrhal conditions,
Mental,
mental emotional disturbances. Yeah, I really don't see the young people on all these junk foods as being as healthy as all of that myself. Anyway. Right, shall we have a break for a little while? Recovery factors. Made the point quite clearly, I think, that environmental factors are paramount, and these are things that we can manipulate and regulate most easily. Obviously, we're unable to change the hereditary factors. So the areas where we can bring about changes are changes of environment and, of course, changes of use. And, of course, this involves, of course, the total impact of lifestyle change. Lifestyle change means that we're influencing the environment, and we're also influencing the person's pattern of use. Now, in my practice, something that I employ fairly extensively in dealing with the sick is a process of fasting. Now, fasting has enormous remedial benefits, advantages, and it can be rather complex. But by fasting, first of all, we'll start with some sort of definition. I mean the voluntary and complete abstinence from all food except water, looking upon water as an important nutrient. Now, the word fasting does tend to be a little bit confusing because you'll find in the literature people referring to juice fasts and things of that type. Now, juice fasting is a contradiction because to fast means to abstain. So if you're on a juice fast, it would mean that you're abstaining from juice. And of course, they mean that you're taking juice. But anyway, from my point of view, fasting is the complete abstinence from all food except water. And that period of time may be anything from missing a few meals to a considerable period of time. The longest fast I have personally conducted is 103 days, which is quite a long time, but there is a case on medical record of somebody who fasted 384 days. That's well over a year. But
Very heavy.
yes, of course, the person in the medical literature, that person was fairly enormous. We're looking at somewhere 400, 500 pounds. The person in my experience that fasted 103 days was approximately 200 pounds. They lost 97 pounds during that fast. And in actual fact, that particular case was the one I was referring to earlier, which I considered myself terminal. This 46-year-old male who had been discharged from Sydney Hospital with malignant development in the lungs. The right bronchus was completely occluded and the right lung collapsed. There were multiple secondaries in the axilla and in the other lungs, the other lung. And, well, I personally didn't think there was much hope of recovery, neither did most of the other professionals that had been seen at that particular time. But this patient did decide they wanted to fast, and we thought we'd go ahead and see what happened. Well, over that period of time, gradually the tumours were autolyzed and the lung did reinflate after about 85, 90 days. And the person did ultimately recover. And I say no one was more surprised than myself. But such an unusual experience is fairly unique. It doesn't always happen like that. Fasting, if we're just taking water, is a process that's almost as common as feeding in nature. You notice that sick and wounded animals will commonly fast. Domestic animals will often refuse food if they're sick. And there are literally scores of examples in nature of animals fasting in sickness, when wounded, injured, and of course at different periods of life, mating season, reproduction, metamorphosis in insects, of course, changes of that type. As far as human fasting is concerned, it's something that goes back to antiquity, mentioned in all the old books. The Bible refers to it many times. And it's been used remedially, it's been used for discipline, it's been used for developing clarity of mind. It's been employed in a wide range of things. Religious disciplines have often and are noted for the employment of fasting and the development of a disciplinary life. But fasting in the so-called therapeutic sense or in the remedial sense may have been used for a long period of time, but documented work on it is fairly scant until recent times. During the 19th century and early 20th century, fasting experienced a period of popularity. There was quite a number of books written on the subject, and a lot of vaguely empirical and experimental work was done with the subject. But I think the really first scientific appraisal of the subject of fasting was probably done by Francis Garneau Benedict at the Carnegie Institute, who published his findings in the book A Study of Prolonged Fasting, which was published in 1915. And he might be considered the father of the scientific investigation of the subject of fasting. His subject, Professor Levanzin, fasted, I think, 31 days. During that time he was subjected to extremely close scientific observation. Now, a lot of work has been done probably in the last 2 or 3 decades to enable us to understand the mechanisms that are involved in fasting. Now, if we look at acute disease that we have talked about, pneumonia, smallpox, typhoid, cholera, poliomyelitis, the common cold, any acute disease as a matter of fact, you will observe, or if you look in the medical texts, you find that one of the first symptoms to arise is anorexia, or loss of appetite. We find often that the body has a coated tongue and a foul breath, impaired sense of taste. There is loss of appetite. The body is indicating fairly unmistakably that it doesn't want food. But we are in a certain amount of conflict, of course, because we are educated to believe that the sick, more than any, require plenty of good nourishing food. The hygienist, of course, would argue the opposite. We would say that that's the last thing the person needs, because they're not able to handle it. There's no point in forcing food upon the sick organism when there is no ability to utilize and appropriate it. Now, the person has lost their appetite, they're fasting. How does the body derive its energy? First of all, we realize that glucose is the major source of energy in the body, that we function largely through carbohydrate metabolism and to some extent through fat metabolism to elaborate energy, that the basic coin of the body's energy is adenosine triphosphate, derived by the oxidation of glucose. Now our glucose level is going to, or our glucose stores, is going to diminish very quickly when we stop eating. In fact, within a matter of a few hours of ceasing to eat, our blood sugar level will start to fall. In fact, going from an evening meal to a breakfast meal, we notice that the blood sugar level will drop quite significantly. Now, I don't know whether in this country you use standard international units or whether you use milligrams percent or what, but we'll talk in terms of milligrams percent. I think that's the one I've seen most familiarly in the literature here. Normal blood sugar level ranging from, say, 80 to 110 milligrams percent. We find that often in an overnight period without food between the evening meal and breakfast, that the blood sugar level may fall to below 80 milligrams percent. Now, if the person continues fasting, and they skip breakfast, and many people, of course, even not fasting, will skip breakfast. Many people wait until lunchtime before eating. The blood sugar level may fall to 60, 65 milligrams percent. So the sugar reserves of the body, which the body has no specific reserves of sugar, but it does have a reserve of a readily available source of sugar in glycogen, which may be in the muscles and is stored significantly in the liver. Well, after a few hours of abstinence from food, the body will be well into breaking down its glycogen reserves. And so therefore we have the process of glycogenolysis, and the body is maintaining its blood sugar level from its glycogen reserves in the liver and muscles. This won't last very long either. In fact, in a period overnight towards early morning, we do find an increase in circulating amino acids, lysine, alanine. The fact that the body is breaking down protein to maintain blood sugar. And protein breakdowns occurring, gluconeogenesis is occurring as a result of the process of abstinence. The glycogen reserves in the liver might last for maybe 18 to 30 hours, but at that time, for practical purposes, they will be pretty well exhausted. But as the person continues to fast, protein will start to supply glucose, and we'll start to break down muscular tissue to maintain our blood sugar level. Now, the glycogen reserves are never completely exhausted. The body will always retain a certain small quantity because of those emergencies that the body always seems to anticipate. So glycogen reserves are never completely exhausted. But the blood sugar level reaches virtually a fundamental basal minimum after about 24 to 36 hours, and this will vary once again quite significantly from one patient to another, one person to another, one subject to another. We might find it down around 40 milligrams percent in some, 50 to 60 milligrams percent in others. Now, quite obviously, it is not a good strategy that the body supply protein as a source of energy. Whilst protein is energy rich, it is not the best source to derive our glucose or blood sugar from. We don't have any specific reserve of protein in the body, although I suppose somewhere in the region of 6 kilos of the average person is protein. Most of that is important functional tissue. So we don't want to subsist for very long on protein, and in fact we don't. Within a relatively short period of time, something like 36 to 40 hours, fat metabolism will take on a different function. The breakdown of fat, the mobilization of glycerides and the increase in glycerides in the blood will be an indicator of the changes that are taking place in fat metabolism. And we find that the person goes into ketosis. The breakdown of fat is now producing significant quantities of ketones, acetone, acetoacetic acid, desoxybutyric acid, and these will be gradually accumulating within the blood. They will be excreted from the kidneys, and it's quite easy to observe after a day or so, if you perform a simple urine analysis, to discover that ketones are appearing in the urine. Do a blood analysis, of course, you find that ketones are significant in the blood. Now, around about this time, 2 or 3 days, we find that the body starts to use ketones as a source of energy. It no longer is utilizing glucose as its basic currency for energy, but it is using ketones. And it's important to recognize a clear distinction between fasting ketosis and something like diabetic ketosis. Now, diabetic acidosis is a very serious condition, and what we have in diabetes is the production of large amounts of ketones along with a high blood sugar level. In the fasting subject, we have the production of ketones from the breakdown of fat with a physiologically minimal blood sugar level, a low blood sugar level. And that's the key. It is the low blood sugar level and the high ketones that triggers the mechanism within the organism to utilize the ketones as a source of energy, as distinct from the diabetic who does not use the ketones as a source of energy. So the two should never be confused, and often I find that medical people, specialists, will say, look, that's the same as acidosis, that's a diabetic situation, very serious. And they virtually label it a disease called ketosis. But ketosis is a natural physiological phenomenon during times of deprivation, scarcity, and it's part of the body's ability to adapt to this environmental situation, which would certainly arise from time to time in a natural environment. And one observes in nature that animals are frequently cut off from food for fairly lengthy periods of time. So it is a fundamental means of survival. The fact that we can get food by just going down to the store doesn't mean to say that the body in its original sense was aware of that. It had to consider all the possible eventualities that an environment may be thrust upon it, where we can't just go down to the store and buy some food, that we may have to subsist for a fairly long period of time without food, so hence there is a mechanism within the body that will handle this situation. So after just 2 or 3 days of fasting, we get into the situation of ketosis, where the fat is being broken down, producing ketones, and these are being used by especially the insulin-dependent tissues of the body as a source of energy. As a result of the work of Carl at Harvard a few years ago, and the work of Owen in London, it's also been demonstrated that even the brain is capable, which of course we know is not insulin dependent, is also capable of using ketones. But there is apparently a very small area in the higher centers of the brain that still require glucose. And that very small amount is supplied during the fast by the breakdown of protein. But the breakdown of protein is minimal. The breakdown of fat is high during the fast. So fasting does occasion a large breakdown in the fatty deposits within the tissue, which supply the ketones, which supply the energy. Now, a point about fasting that I'd like to just mention as an aside here, that I am opposed to, and that is this fasting that has become very prevalent in certain quarters of people fasting 1 day a week. I've read this in a number of books, that it's a good idea to have a fast 1 day a week. I don't think it is a good idea to fast 1 day a week, because I have just mentioned some of the adaptive processes that are necessary when one attempts to fast. All of those adaptive processes will take place in the first day or two. Now, if you fast 1 day a week, you do not utilize fats as a source of energy. You're essentially utilizing protein, because that's during that adaptive phase. You are also recognizing that we must consider that that first day or so, during those adaptive periods, is a fairly energy expensive process, because adaptations are taking place. And consequently, we find that with those adaptations we may get such symptoms as tachycardia, feelings of nervousness, irritability. They may be more associated, of course, with the withdrawal of one's accustomed stimulants. But nevertheless, there's often changes in blood pressure, heart rate, and things like that, which are associated with glandular changes, increase in adrenaline secretion, because of the initial adaptation. Now, the person who's fasting 1 day a week is merely putting the body in a position where it has to keep making this adaptation and then revert back by adapting once again to normal feeding, which I don't think is a good idea to just keep on doing on a regular basis. And of course there's also the thing that's so fundamental to fasting, that is the point I mentioned earlier about anorexia. And if you decide to fast 1 day a week and you're going to choose Monday as a fast day, it won't be long before you begin to hate Mondays. As you wake up on Monday morning with a roaring appetite that today is your fast day. Now, that's not really a good hygienic principle. Now, probably something that might have been implicit in what I've said so far, but we'll make it explicit. The fact that in hygiene, what we're trying to do all the time is to interpret the needs of the body and to assess the capacity of the body and make judgments accordingly. So these two concepts of need and capacity are vital. An organism has certain needs: food, air, water, rest, sunshine, activity, mental and emotional influences. All of these things may be considered as being among its needs. And recognizing each individual organism as unique, it has a capacity or a limitation of its own. So we have to recognize this individual capacity or this individual limitation. So making a judgment between the need and the capacity of the organism is something that we must try to do all the time. And this is especially so when we're dealing with remedial processes, when we're dealing with the sick organism. Because we don't have the same leeway, we don't have the same area or margin of error when you're dealing with the sick. So assessments of needs and assessments of capacity must frequently be adjusted and modified to suit the circumstances of the case. So we want to get rid of this idea of people fasting 1 day a week. Now, Roy Walford, who's written a book on longevity, is a professor at the University of California in Los Angeles. He's written quite a bit on fasting. Now, he is one who will overeat for 3 or 4 days of the week and then fast the rest of the week, realizing that probably the optimum thing for health and longevity is a low-calorie diet. And we'll talk about diet later. But that's the point that he's come to. And this has been supported by Carlson, Holson, Holzo, Kund, Childs, and various investigators of the problem of aging and the physiopathology of aging. And they know that a high-calorie diet is actually age-producing, or age-accelerating, I should say. Now, Walford, of course, prefers to eat the high-calorie diet for a few days and then fast. I don't believe that that is nearly as good as maintaining the restricted calorie diet in one's general lifestyle and working more towards optimum utilization of calories rather than consuming a calorie excess. Because once again, working on the principles of need and capacity, if we can look upon food as supplying a fundamental need and capacity as being something that we can enhance, then we can improve the body's ability or capacity to utilize that need. Therefore, if we can supply that need in a different form, thus not taxing the organism excessively, we can achieve a maximum performance and, of course, maximum lifespan. From my point of view, although it's partly theoretical, I don't believe it is possible for a person to extend their lifespan. I think we can only shorten it, which most of us go about doing fairly diligently from a very early age. If we are born with a certain potential, we have to find out how much of that potential we can actualize. But there was no way we can go beyond that potential. That is a given, once again. It is resident within the organism. It's part of the organism's basic constitution. But it may have a capacity to function in a certain way for a certain period of time, maybe 120, 130 years. And depending on how we utilize that organism, on how we supply it with its needs, and how we stay within its capacity, we might get 60, 70, 80, 90 years out of it. Or if we're very lucky, a little bit longer. But we're not going to work towards extending that potential. We can only extend the actual within the potential. Now, the work that's been done on fasting has been extensive. The regeneration and the rejuvenation that comes about as a result of fasting is quite phenomenal, and is something that generally has to be seen or experienced to be believed. Now, I think first of all we should look upon fasting as a physiological rest. Now, when we consider all the energy that's expended on the consumption of food and the utilization of food, it's quite significant. The process of eating the food, on masticating and elaborating the salivary fluids, the swallowing of the food, the digestion of the food in the stomach and the small intestine, the elaboration of enzymes and the gastrointestinal fluids, the absorption by active transport, which of course is an energy expensive process, the circulation and distribution of the nutrients, the modification and process of the nutrients in the liver, the delivery of the nutrients to the individual cells and tissues. All of these processes are energy expensive. Now, if the food happens to be reasonably nutritious, when the molecules are picked apart at the intercellular level, then maybe we'll get a little bit more energy back from it than we've actually put into it. If the food happens to be of poor quality, of course it will be even less. So the efficiency of the organism is probably only about, as an energy or fuel-using apparatus, is not very great, probably only around 15%.